In today's lecture, I would be focusing on the signs and symptoms of basal ganglia disorders. Here in this particular chart, I have enumerated all the signs and symptoms along with a picture of the Parkinson's patients, which I would be explaining in due course. Coming back to the basics of the basal ganglia, the basal ganglia is connected between the cortical association area and the premotor cortex and motor cortex. The information going from a cortical association area goes to the premotor cortex. Along with that, it consults the basal ganglia, and then their inputs are also considered for the voluntary action. This is the voluntary action. Now, here, if you are looking at this point here, the same thing, cortical association area sends information to the basal ganglia, and the basal ganglia in turn talks to premotor cortex, and then premotor cortex gives back the information to the basal ganglia. Then it will come back to the motor cortex, that is motor cortex, and then subsequently to the motor neurons of the spinal cord. So that is the plan of voluntary movement, which I have been discussing about. Now, moving further, these are, in brief, these are the parts of the basal ganglia. Here I have named 5 parts. The caudate nucleus, this is caudate nucleus. These are lateral ventricles there. These are 2 thalami, caudate nucleus. Then this is putamen. This part is putamen. This is also blue, and this is also blue, and they are put together. They are known as a striatum. Then we have these pinkies, the globus pallidus externa, globus pallidus interna. And these globus pallidus interna, externa, and the putamen put together, they are known as a lentiform nucleus. Then we have this is thalamus, the subthalamic nucleus here. And then the substantia nigra, this yellow one is the substantia nigra. Now the brick red, this part is the pontopeduncular nucleus. These are the basic parts of the basal ganglia. I repeat: caudate nucleus, putamen, globus pallidus, subthalamic nucleus, substantia nigra. I have numbered them 1, 2, 3, 4, 5. In addition, the pontopeduncular nucleus and the thalamus, they receive inputs. Whatever the outputs coming from the GPI, they go to the thalamus and to the pontopeduncular nucleus. Now, these are the connections of the basal ganglia. The first one is the direct circuit, which I explained in my previous class, wherein the premotor cortex gives to striatum. From the striatum goes to interna, globus pallidus, and then to the thalamus and the motor cortex. Here is the loop. This is the premotor cortex to the striatum. Striatum consists of caudate nucleus and putamen, and then it goes to the globus pallidus interna, and then from the globus pallidus interna, the fibers reach the thalamus and back to motor cortex. Part of the information also reaches to the pontopeduncular nucleus of the reticular system, especially the brainstem reticular system. And from the motor cortex, the corticospinal tracts descend, and in the medulla, they cross to the opposite side. So that means whatever happens to the right side of the basal ganglia, it will affect the motor functioning of the left side. So that means the contralateral side. This is a direct path. Yesterday, I mentioned about what happens to this direct path, because you have one transmitter here, excitatory transmitter here. This is GABA here, inhibitory transmitter. GABA here, inhibitory transmitter. and then glutamate here, the excitatory transmitters. The product of plus minus minus plus minus minus would be plus. So that means the impulses reaching to the motor cortex and to the pontopedunculaar nucleus are excitatory in nature, and they produce increased or hyperkinetic activity. So that is why the arrow thickness is more. This is about the direct circuit. Now we have the hypokinetic loop or indirect circuit. In this indirect circuits, what happens from the striatum, that means from the premotor cortex, it reaches to the striatum, the excitatory inputs. The striatum sends information to the globus pallidus externa, and from the globus pallidus externa, it will send information to the subthalamic nucleus, and the subthalamic nucleus in turn communicate to globus pallidus interna, and the globus pallidus interna again talks to thalamus, and from thalamus it is going to motor cortex and the pontopedunculaar nucleus. If you are looking at the circuitry here, it is a plus minus minus plus minus plus minus minus plus minus. And if the product of all these things would be minus, thus the output going from thalamus or inhibitory or hypokinetic. So if you are looking at the previous one, this arrow from thalamus to cortex was a thick arrow I made. Here I have made a thin arrow that indicates it will be inhibitory. The impulse is reaching here or fewer or less. That is the inhibitory circuit or the hypokinetic loop. Then I mentioned about in addition to these two direct circuit and indirect circuits, this is the direct circuit here. This from here to here is the direct circuit. Indirect circuit here through the GPE subthalamic nucleus, and there is one more the basal ganglia nucleus in the midbrain, that is substantia nigra. These substantia nigra, so this sends a dopaminergic neurons to the striatum, what is known as a nigrostriatal tract. The substantia nigra receives the inputs from several parts of the brain, especially from the premotor cortex, which are not shown here, from the premotor cortex, then the nucleus accumbens, from the brain stem, and various other regions of the thalamus, and all other parts they give the information to the pars compacta. So that means whatever information going there, they would be excited. Now, this nigrostriatal tract, that means substantia nigra, has two components. One component is pars compacta, that contains the dopaminergic neurons, and the substantia nigra reticularis, that the pars reticularis, that contains GABAergic neurons. Now, what happens to the pars compacta? So this will refine the direct circuit activity or indirect circuit activity. That means hyperkinetic motion or hypokinetic motion. If you are looking at that, so the nigrostriatal secretes dopamine. The neurons which are reaching to GPI from striatum are expressed with the dopamine 1 receptors, and these dopamine 1 receptors are excitatory in nature that further enhances the activity. This is a direct circuit. Indirect circuits, this inhibits there, and the inhibition leads to the greater inhibition of the thalamic output. So that means these two things, they are acting as a fine tuning, and this fine tuning is further adjusted by the intrastriatal cholinergic neurons. And these cholinergic neurons, acetylcholine exerts its action on acetylcholine receptors muscarinic receptors and the nicotinic receptors. The neurons in the direct circuit are expressed with the muscarinic receptors, which are inhibitory in nature. So that means this is more the dopamine one, the dopamine excites or increases the output of the direct circuit, and the muscarine suppresses the output of, so there is a balance. Similarly, the dopamine 2 receptors that decreases the output, and that will be balanced by the nicotinic acetylcholinergic actions. This is in brief about the overall circuitry of the basal ganglia. Now, so I have also mentioned there are 4 neurotransmitters here. First one is a glutamate. This is glutamate here. The blue ones are the glutamate, and this red one are the GABA. That means from the striatum to the globus pallidus externa or to the globus pallidus interna, it is GABA. From the globus pallidus to subthalamic nucleus, the pallido-subthalamic tract, it is GABAergic. Then subthalamo and pallidal, this is a glutamatergic, and from the pallidothalamic tract is GABAergic. So now thalamocortical projections are glutamatergic. That is what I have mentioned here on the back, on the side of this particular these things. Now, moving on, in the last class, I mentioned about the functions of the basal ganglia. I repeat, the planning, programming, and sequencing of the voluntary actions. So that means the voluntary actions is split into a number of items, and all those plannings and programming, including the sequencing, is done here. Then the second part is the execution of the pattern of movements. The pattern of movements, walking, talking, running, swallowing, or whatever the patterns are to be executed, and they are executed. And this is through the putaminergic circuit. So that is originating from the premotor cortex, the motor cortex, and then comes to the striatum or putamen. Then from putamen, through direct and indirect circuits, it comes back to thalamus and back to the motor cortex for action. Then there is a third function is the cognitive control of motor action. That is a caudate circuit. This receives inputs from the entire cerebral cortical areas, starting from the prefrontal cortex, the insular cortex, then the limbic cortex, and then the sensory cortex, and the occipital cortex, that is visual, and auditory cortex, that is for the auditory signaling. And all those things are combined together. That gives the cognitive component, that gives the cognitive aspect of the particular event, and that is analyzed through the hippocampus and other areas of the brain, including the prefrontal cortex, and brings about the voluntary action. I mentioned about the other day about the snake in the bed, how you jump out of the bed, or any blast, or any other conditions, or for any action, there is always a cognitive or learning. So we have already knowing that particular action, what it does. Okay, so that cognitive control of the voluntary action. So that means you are standing on the cliff and suddenly you lose the balance. So at that time, you don't have time to think. You have to balance, or you have to bring back. Otherwise, you will fall down in the valley. So that is come back to the normal is a cognitive component. Then timing of the voluntary action. So that means when to, whether that means if you are passing a road, whether you would be able to pass a road between the various vehicular traffic, or placement of a ball, or giving a shot, or doing any voluntary action. So that is the timing. Then scaling. I mentioned about the scaling, the writing on the paper, pen, or writing on the chalkboard. So you just see the difference you create in the size of the letters. that is scaling of the voluntary action. Also, if you have to throw a ball for 5 meters and if you have to throw a ball for 50 meters, the intensity of or a force you use to utilize that. So that is a scaling. And modulating the muscle tone and posture as required. Yesterday, I have shown number of pictures wherein every action is associated with a posture, and that is to be modulated according to the plan of the work. Then the basal ganglia dampens the oscillations, normal oscillations present in the agonist and antagonist group of muscles. So these agonist and antagonist group of muscles have a continuous oscillations, they are suppressed. And then that is why we don't have tremors. So these are the dampening of the oscillations. Then the basal ganglia acts as a switch for the voluntary action, either turning on or turning off. I just list here the disorders of basal ganglia. So one is Parkinson's disease. It's one of the important things for your examination point of view. Then comes the Huntington's disease. Then we have a Sydenham's chorea. Then we have dystonia. Then we have a ballismus or hemiballismus. It is because of the subthalamic involvement. Then we have a Tourette syndrome or tics, unwanted repeated movements or sounds. That is another disorder. So that means there are persons who are always trying to do some movements, either eyeball movement or the facial features or the hand movement. These are called tics. Or some of the patients, they will vocalize, they say some words. So some maybe these words, these are unwanted words, they produce the sound, and I don't know, that vocalization is also a part of the tic. Then we have a Wilson's disease. Wilson's disease is a basal ganglia disorders where there is a degeneration of the lenticular nucleus, hepatolenticular degeneration. Copper accumulates there, and then that would destroy this lenticular nucleus. Then we have tics. These tics are here in the Tourette syndrome. Then there are tardive or spasmodic dyskinesia. These are the disorders of the basal ganglia. Of them, what we will be discussing most of the time, the Parkinson's disease, the Huntington's disease, ballismus. Then we have these tics. Maybe I would deal with them in the subsequent class. Now, about these are the disorders, and all these disorders have one or the other type of manifestations. One or the other type of manifestations I have listed here. So now I have listed nearly 12 the signs and symptoms of basal ganglia disorders. The manifestations, I means how these patients with the basal ganglia disorders present to the doctor. So now one of the thing is a tremor, a resting tremor. This is a continuous rhythmic motion. That is one. Then the muscle is rigid. That is a rigid muscle rigidity. The first second is the muscle rigidity, and this rigidity is the lead pipe or cogwheel. Then there is a poverty of movement, that is called echinacea or bradykinesia, poverty of movement. Then there are abnormal dance-like movements, that is chorea. Then there are sudden flail movements, so sudden jumping of the limbs, like this flailing of the limbs, that is ballismus. Then there are what are called ptosis, that is the slow riding movements. If you see this thing continuously, you will have a very slow motion, the slow riding movements, that is ptosis. Then dystonia is a sudden contraction of a particular group of muscles, then not able to perform any actions. So resulting in the abnormal posture and abnormal motion, even leading to falling down or slipping. Then disturbance of posture and equilibrium and tone. So that is a disturbance to posture and equilibrium and tone, or seen as a posture. That means a posture of the basal ganglia disorder. He will have a stooped, especially the Parkinsonian posture is a stooped posture, that is a universal flexion. Then the gait changes. Gait is the fascinating gait, as though the person is counting the gates, the steps. These are short steps, then slow and counting one another, the fascinating gait. Then we have the speech because of the echinacea, because of the rigidity, because of the tremors. The speech is stuttered, slow, and poorly articulated. So speech disorders. So then the writing disorder. So that means he is not able to write fluently. So and even the writing, the scaling becomes minimum because of the hypokinesia or bradykinesia. So that means there is what is called a micrographia. Then the tics, that means abnormal movements, are this movements of the eyeball, or the movements of the tongue, or the facial muscles, and so on. So these are some of the signs and symptoms. I just read again: tremors, rigidity, echinacea, bradykinesia, chorea, choreatic movements, ballismus movements, ptosis, dystonia, altered posture and equilibrium, the gait, altered speech, micrographia, and tics. These are the signs and symptoms of basal ganglia. Now, examine these signs and symptoms one by one. Now, tremors of Parkinsonism. These tremors of the Parkinsonism are rhythmic movements. Tremors are rhythmic movements. These tremors appear in the resting. When the person is resting, he always have this type of tremors. You can just see that these are coarse. You just see that these are coarse tremors, and also it will be see as if the rolling the pill in between the hands. You can just see, if you can see my hand there, a pill rolling tremors. These are resting tremors. When person at rest, even if he is keeping in the side, though I am just trying to elevate my hand here, so he cannot do like that, and then he will have a continuous pill rolling motion. That is the type of tremor. And these tremors, if they start performing action, they disappear. So that means they disappear by when person begins to perform. And it is because of the lack of inhibition, which the GPI, the basal ganglia outputs, reach to the pontopeduncular nucleus, because the pontopeduncular nucleus controls the pattern activity of the these rhythmic actions of various excitatory in these agonist and antagonist group of muscles, in addition to the cortical, these things. Now, the lack of inhibition, if these are not dampened, agonist and antagonist group of muscles, they will oscillate. Now, the tremors of Parkinsonism is often discriminated by the tremor of the cerebellar disorder. In the cerebellum, what happens? The tremors happen when a particular person tries to bring in certain objects, reach the certain objects, then he will have a tremor in holding it. Just like if you are going and trying to hold a cup or an object, when you reach the near the object, there will be a sort of a this thing, that overshoot or undershoot mechanism, in which the muscle movement will go. These are called action tremors. So that means they are not resting. So when the particular person performs an action, that is the tremors are. And these action tremors are limited at that time only. They are not pill rolling, and they are present during action. And it is because of the cerebellar that particular checking or the comparator aspect, the servo inhibition is not there. There is a overshoot or undershoot. The servo mechanism fails. That is about the tremor of the cerebellar disorder. Now, rigidity. In the basal ganglia disorders, the muscles are rigid, especially in the Parkinson's disease. The muscles become very rigid, tight. And the rigidity here is sort of a both agonist and antagonist group of muscles. Here, the biceps and the triceps both have contracted. If both have contracted, you can just say that a particular limb position, it is something like a pipe or something like that. It is, say, for example, I just push it, so you have a rigid. And if somebody wants to bend it, no, you cannot bend it, because both the extensor and the flexors are the agonist and antagonist group of muscles are contracted. So that is a lead pipe rigidity. And when you try to flex it, or when you try to bend it, you cannot bend it. It appears like a lead pipe. Or sometimes it may give away, but it does not give away just like a clasp knife rigidity as it happens in case spasticity. Here it gives away as if it is in a stepwise manner, cogwheel rigidity. So rigidity here, lead pipe rigidity as a continuous resistance, or the intermittent resistance. So that means it gives in a breaks. It gives in a breaks like this. So cogwheel type of rigidity. Rigid throughout the passive movement, as if bending a lead pipe, or gives away intermittently, as happens in case of a cogwheel. The rigidity or stiffness or inflexibility of limbs, it can happen with the limbs, the neck muscles, the trunk. This is a primary motor symptom of the Parkinson's disease. Now, this rigidity leads to what? The stiff, inflexible muscles and do not swing while walking, because the muscles are rigid. The person cannot move it. They are not loose. They are not loose. They cannot move this thing. They cannot swing while walking. Because of the rigidity, there may be pain and muscle cramps are seen. Because the muscles are contracted continuously, there may be muscle cramps and pain. And because of the rigidity of the facial muscles, the facial muscles become fixed. These are called a mask-like appearance of the facial muscles. Now, in the person, the patient he complains of he cannot turn the other side, turn to the other side when sleeping in the bed. So that means a difficulty in turning over in the bed. Even because of muscles are rigid, he cannot get out or start to move from one point to other point, because he's almost frigid. Similarly, because of the rigidity, he will have a trouble in doing any action. These actions may be writing, or trying to give an object to one, or buttoning the clothes, or performing a routine activities, going to the bathroom and taking a toothbrush and toothpaste. Because a toothbrush and toothpaste, you have to hold the brush and you have to take the cap of the toothpaste. Then see, so many complex movements are there, and squeeze the paste, and then that requires energy. So they have a complex, they have a problem in doing these routine activities. Here I have just mentioned writing, buttoning clothes, or performing routine activities. So this is rigidity, and this is what I was trying to talk about, a cogwheel rigidity. Cogwheel rigidity means breaks as if in cogwheel. Cogwheel means you must have seen how it happens in case of a one teeth to the another teeth. So that means I can just give you an example of the bicycle. In the bicycle, the one wheel is the cogwheel, and then that takes up the chain and then moves to the next stage, something like that. So that type of rigidity. That means in a stepwise manner it moves. Then bradykinesia or echinacea. The bradykinesia or echinacea are poverty of the movement. The movements have become weak. They do not have enough strength, and this is because of the inhibitory aspect. So that is the hypokinetic motions or hypokinetic circuitry is activated. Bradykinesia this term is often used as echinacea and hypokinesia. Echinacea means absolute loss. Echinacea refers to the poverty of the spontaneous movement. Like facial expressions when we are talking, or associated movements when we are moving, that is the arm swinging during walking. And bradykinesia is a slowness of the movements. So that means he goes one very slowly to the destination. That means you can see in the gate there is a fascinating gate. So the other manifestations of echinacea are the freezing. Sometimes the person is not able to start or not able to perform any actions. That is freezing. And even if he wants to get out of that, and he takes prolonged or a very long time to get out of that particular freezing motion. So that means the echinacea is associated with the freezing and the prolonged time it takes to initiate the movement. So that means a person is sitting on a chair and he takes a tremendous amount of time because of the one, rigidity, the second, the weakness of the muscles or the poverty of the muscles. He will not develop enough tension to get up, because if I were to get up from this chair, I have to develop the tension in all my posture muscles, including I should develop the tension in my leg muscles so that I can give a thrust to the ground and then I get up. So that means you can just try to imagine that. So now that thing happens, so that initiation taking longer time for initiating the movement. Hypokinesia refers to the fact that in addition, it is slow, the movements are smaller. So that means there is two aspects in the hypokinesia. One, the slowness, and the second, their intensity is less. Slow and small. Actions are small or intensity is less. Little force is developed. This is slow and the intensity is smaller. So this can be depicted in as a micrographia is one of the example. The patients with the Parkinsonism will have the writings. They may start large with the initially, then slowly they become smaller and smaller, and finally they are becoming faint. They finally disappear. These are called micrographia. Then chorea. This is a typical chorea moment. You just see that these are not patterned. So he may have see, look here, the limbs here, and this limb, the neck, this side, and the lips, and the tongue, and the eyes, and this. So that means this is a totally disorderly array of movements. These are hyperkinetic movements. The person will not be able to see that. And the chorea is a hyperkinetic movement, presents with a rapid, unpredictable contractions affecting mostly distal limbs, here, these limbs, but also the face and the trunk. Includes the muscles of face, jaw, and trunk. You can just see that. The movements are involuntary and non-patterned with variable speed. Sometimes they are slow and sometimes they are fast. And the directions are also different. And giving an appearance of a frigidness, frigidness, that means a slowness of the motion. Unpredictable nature of chorea distinguishes it from the tremor and dystonia. Dystonia is a painful contraction or a contracted, spasmodic contraction of the muscle. A tremor is a oscillations. This is chorea. Maybe I may just like to show you some choreanic motions. Yeah. So these are choreanic motions of an individual. You can just see that even the limb here, this limb and this limb. This is one of the choreanic motion, and that's what you see. Okay, so now, so this is about chorea I mentioned. Then comes we have the ballismus. It's the involuntary movement. You must have seen persons sometimes going in the street and suddenly they throws away the limbs up, something like that. They throws away the limbs, or these ballismus, hemiballismus is only one half of the body is affected, and continuously the movements are happening. Continuously the jerking and flinging motions are happening in the extremities. And this is because of the involvement of the subthalamic nucleus of the opposite side. And usually one side of the body is involved, that is a hemiballismus. Let us see some of the hemiballismic movements. This is a hemiballismus. You can just see that. Can you see that that lady is continuously this limb and this limb? See, these are hemiballismus motions. Okay, so now. So this is another example. See, they are just these are ballistic hemiballismus. This side is a particular motion, particular motion. So look at that. See how she is performing with this. Okay, I stop here. This is choreanic motion. You just see this individual. These are choreanic motions. These are choreanic motions. This individual, you can just see that. So these are choreanic motions. Continuously he just maybe see moving the entire neck, and suddenly see the jaw movement, the lip movements, and yeah, the limbs. See that limb, how he's, these are choreanic motions. He just tried to, he was asked to make the limbs there, and he was not able to control. See how he is trying to do that. So these are choreanic motions. The ballismus I mentioned, usually one-sided. These are flail-like movements. These are jerky movements. You saw that those two ladies, they just throwing their limbs in a different posture. Then ectosis. Ectosis are slow riding movements. If you can just see what these are slow riding movements continuously. They are movement, and they are not flail like ballismus. They are slow continuously. Even it may happen the arms, legs. So if we were to toes and feet and all, even the tongues, fingers. These are fingers. It's just slow riding motions, and these slow riding motions seen in alternating movements. That means with of the agonist and antagonist group of muscles. So they can be indicated by a flexion, extension, just like this, or a supination and pronation, just like this, or a foot. You can see the eversion and inversion, or lips retracting and pursing, and twisting the neck, or winking, and relaxation of the space, just like this. just like this. The voluntary movement is slowed due to the hyperactive antagonist group of muscles associated with the rigidity and the corticospinal involvement. Hypotonia is seen in this ethetosis. Maybe we will see some ethetotic movements here. Yeah, this is ethetosis. You can just see that how the fingers, so he is trying to make that ethetosis movements. These are ethetosis. Okay, so now these are ethetosis movement, and here I have just trying to I have shown the actual video clip of that, and these are ethetosis movements. You can just see how particular motion, including the motion of the facial features. Then dystonia. Dystonia is a hyperkinetic movement disorder in which a sustained and repetitive muscle contractions result in twisting and repetitive movements or abnormal fixed posture. You just see this individual. Here is the drop attack in this boy, wherein suddenly all muscles are going into a spasm. As the dystonia, it is a hyperkinetic movement. It's a hyperkinetic movement disorder in which a sustained and repetitive muscle contractions result in twisting and repetitive movements and abnormal fixed postures. Here he drops down. Here there is a tonic spasm of the left side. So in this child, and here it is the respiratory group of muscles are activated. So they are changing. So there is a hyperventilation. So this individual, including the other accessory respiratory muscles. Then here in this case, acute dystonic reactions, oculogyric, that means the movement of the eyeball, they will go into a spasm, or oropharyngeal. So you have that. These are dystonia, and dystonia can affect different body parts, and often the symptoms of dystonia progress through the stages. Some early symptoms include a dragging of leg or a cramping feet, involuntary pulling of the neck. Sometimes we do have that because of the abnormal posture or attitude we have adopted during sleeping. Uncontrollable blinking, that is a repetitive action. Uncontrollable blinking, some persons have that dystonic blinking. Or there are speech abnormalities. They may end up with a stuttering. So these are dystonic features. Then comes the disturbance of the posture. The posture is not, it's peculiar. So most of the time the posture is, this is due to decreased activation or inhibition of the medullary, that is a reticular posture regulating pathways. You see this person, he's a person suffering with Parkinson's disease. And here you see that the whole thing, as if the head is dropped, and he is trying to, these are all in a flexion mode. He will be entire flexion, this also flexion, everywhere flexion, universal flexion. The tone of the basic reflex operating at the spinal cord level, there is a diminished gamma motor neuron activity. And this diminished gamma motor neuron activity of the that flexor groups, the posture is the flexion attitude, and with a forward bending. So you just see that almost all joints are in a flexion, that is universal flexion, as if he is carrying a load on his back, just balancing the posture, just balancing to hold on to this posture or stance, and with a great difficulty, as if he is trying to look at the center of the gravity. So that is the what is the picture of the posture and equilibrium and muscle tone. So these things happen here, and if you see that this person has a blank facial expression, hypokinesia, and rigidity of these muscles, the forward tilt to posture, slow, monotonous. This person, when asked to speak, slow, monotonous speech because of the vocal cords have either reduced power, or because there are tremors, or because of the rigidity. Reduced arm swinging, that's echinacea or bradykinesia, rigidity and tremor of the extremities here in the head, and even in the limbs. There will be a continuous tremors. Even the tongues do have tremors. Then short shuffling gait, short shuffling gaits. You see that steps as though he connects one foot to the other, and like that he goes on. This is a fascinating gait or a short shuffling gait. This is about this individual. Now, the gate, we are trying to come back with the gate here. Here, in this individual, same thing, fascinating gate, as though he is counting the steps, small and hesitant. He's not confident. Looking on the ground, he looks at the ground, and balance is not proper, and he's not able to, because he is not able to come back. And sometimes because of the poverty or echinacea, he will not be able to come back to the original. He may fall down because of the weakness of the muscles. So he will have a continuous tremor, continuous persistent tremor, shuffling gait, unbalanced in small steps, the typical universal flexion. That is the gait of the individual. Then speech, slurred, slow speech. It's not continuous. It's broken because already the vocal cords, the contractions are rigid, and the poor contractions, and because the voice is not as loud, it is less audible, and even he has a difficulty in starting the talking or speech. A stuttering, impaired ability of the basal ganglia to produce a timing cues for initiation of the next motor segment of the speech. Because if I were to speak, so I were to speak because my speech is coming in sequence of events or my thoughts. And whatever my thought comes, I'm trying to explain to you. And these sequence or chains are missed. That particular next segment of the chain of the speech is missing. And that is why they are called a non-fluent aphasia. That means there is a aphasia is the speech disorder, and it is non-fluent. Non-fluent means he does not have the fluency. He is slowed down, and it comes in segments, one, and with a pause. That is the non-fluent aphasia. The patient has a problem with speaking his mind, as I was talking, because the sequence and the chain of actions are not executed as expected. The thoughts in the mind do not completely come out of his mouth. So that means the thoughts and the actions of the vocal cords, they do not match. That is why a non-fluent aphasia. There are missing words. Sometimes he will not be able to pronounce them, or he may just they are lost, and the sentences become incomplete. And he finds it difficult to speak, and the emotional components associated with the speech are missing. These are associated. Suppose if one is happy, that emotional aspect of the speech, or if you are angry, the emotional component of the speech, these particular things are missing. This is about the speech. Then comes handwriting, abnormal handwriting, what is called micrographia. So this is the handwriting of a normal individual. The Mary had a little lamb, its fleece was white as snow. So this is normal. This is a normal person. He has written it 3 times without. Here is the same thing. Same, Mary had a little lamb. Its fleece was as white as snow. So I have taken the blue lines indicate the timing. So you just see that this is what the Parkinson's patient has written. You just see that. He started big here, and they are almost they disappear here. They become less and small. See, the second attempt, third attempt have become much smaller. This is called a micrographia. Micrographia because of the echinacea, rigidity, and the repetition is difficult. Similarly, the person is asked to, it's a normal person when he is asked to do this spiral. So he does it wonderfully. But here, this person with a Parkinsonism, what is happening? Because he does it and it becomes a tremors because he has a tremors. He has a tremors. That is why it is not as smooth as this. Okay, this is about the graphical aspects. These are fine things. These are highly evolved the neocortical functions. That means writing and making the pictures or graphs or the drawings. These are all highly skilled activities. Now coming back with the tics. So the tics are abnormal, uncontrolled movements. They happen suddenly and they are for a short time and they are not predicted. Sudden, brief, intermittent, uncontrolled movements. Sometimes these movements may be as sound. So he will vocalize and he says, so I have seen some of my friends, they suddenly they were trying to read, and when they were trying to read, they produce some abnormal sounds or sounds which are really not expected. So like that, these are sudden, brief, intermittent, uncontrolled movements or sounds. These are called tics. It is the tics or blinking of eyes or shrugging of shoulders. So something like that. Or tapping the table. Some of them have the habit of tapping the table, or because of the leg movement, some of them they have the leg movements, or blurt out unusual sounds. Unusual sounds. They are not normal sounds. Sometimes they may be abusive. Then vocalize offensive words. I have seen both the situations with my friends when they are studying and seeing something. Suddenly they come out with explosive sounds. So these are tics. Summary of the manifestations of the basal ganglia disorders: the resting tremor, the coarse, pill rolling, absent, or they remain or they are abolished during action. That means these are resting tremors. Rigidity, lead pipe or cogwheel type of rigidity because of the contraction of both agonist and antagonist group of muscles. A chorea, that is because of the writhing movements and the intermittent violent motions. Sudden violent voluntary movements, that is ballismus. The weakness of the muscles, the poverty of the movements, echinacea or bradykinesia. Difficulty in starting or stopping the actions. Say, for example, if you are having a Parkinson's patient and he is moving, suddenly you cannot stop him, and if you want to stop him, and he may fall down. So, and problems finding words because his speech is not linked each other. So he may have the problems in finding the proper words for the next. Associate the mood changes, not able to pass the items as expected. Say, for example, if you ask somebody to give you the pass the pen situated on the table, so now he will not be able to give it because it requires two aspects. So one, the intensity, scaling, and the timing. Both are required. Timing or just passing the pen like this. You need to see how far is the person and how much is the force, so he will not be able to perform. The timing and the scaling is missed. Abnormal handwriting, I have shown you, there is a micrographia. Abnormal gait, that is a abnormal posture, that is a stooping posture, the flexion, all the things, masked face, fascinating, a short, shuffling gait, uncontrollable repeated movements in terms of the muscles or speech and sometimes cries. These are the summaries or the manifestations of the basal ganglia. So this is what I have shown in the, the title picture. These are all manifestations of the Parkinson's or the basal ganglia disorders. Tremor, rigidity, chorea, echinacea, ballismus, bradykinesia or echinacea, speech disorders, the, the masked facial expression, the starting and stopping of an action, abnormality, the posture, flexion attitude, the gait, the fascinating gait, the tics, the micrographia, or the manifestations of the basal ganglia disorders. Some of the disorders may not, so all these 13 or 14, they may not be there in all the basal ganglia disorders. Some may be missing because depending upon the hypokinetic and hyperkinetic circuits, they are included in the disorder. This is one of the classical Parkinsonian patients. You can just see that short shuffling gait, reduced swinging, and the rigidity and the tremor, and the slow monotonous slurred speech, the flexion attitude, and the blank facial expressions. Okay, the books are the Candles, Neuroscience, the Guidance Textbook of Physiology, Kenong's Physiology, and I have just consulted this Cold Spring Harbor Perspective Medicine about the this basal ganglia disorders. This is the thing. Now, the assignments describe the parts, the connections, and the manifestations of the basal ganglia disorders. Or there is a second question, describe the parts, the circuitries of the basal ganglia, mention various basal ganglia disorders. I have just mentioned the various basal ganglia disorders. Then write short notes on resting tremors, micrographia, dystonia, echinacea, fascinating gait, echinacea, cogwheel rigidity, chorea, ballismus, a stooping posture. In the next class, we will discuss about the disorders of the basal ganglia and those disorders which are of importance to you. Okay, thank you.